So neoadjuvant treatment is really a hot topic in melanoma. Usually it's given for people with a clinically positive disease. What does that mean? People who presents with enlarged lymph nodes, and the lymph nodes could be enlarged lymph nodes in the neck, it could be enlarged lymph nodes in the armpit, it could be in the groin area, and these people could have a history of melanoma before, or they could it could be the first presentation. This is what we call it clinically positive disease, meaning we were able to either palpate and feel those lymph nodes, or we could pick them up on a scan. So again, as I said, it could be the first presentation, or it could be a recurrence. A person, for example, had a prior melanoma in the arm, and now he is presenting to his doctor or primary care with, he feels a knot or a mass in the armpit. Or the scans showed that he has a mass in the armpit. In the past, what we used to do, and up till now actually, it's the standard of care, is to go ahead and do something called therapeutic lymph node dissection, meaning removing all the lymph nodes in that armpit. There are a couple of interesting trials came from Europe. One is called Opacine Neo, and the other one is called the Prado trial. And in this trial, I will discuss more about the Prado trial. They gave neoadjuvant, meaning treatment before surgery, ipilimumab, 1 milligram per kilogram, and nivolumab, 3 milligram per kilogram, IV infusion every 3 weeks for 2 cycles. After that, they went and they removed one of the lymph nodes. They call it the index lymph node, is the largest lymph node in the area involved with melanoma. And they examined it under the microscope. I mean, they sent it to the pathologist. So there are several possibilities. Either there is a major pathologic response, meaning there's only less than 10% of viable tumor cells in the specimen, or it could be partial response, more than 10% or less than 50% viable tumor melanoma cells in the specimen, or no response if the specimen showed that there is more than 50% of melanoma. What is interesting is that amongst people with major pathologic response, that only less than 10% of melanoma cells were seen in the lymph node, these people didn't receive lymph node dissection. They didn't even receive adjuvant treatment. And despite that, at 2 years, 93% were free of melanoma recurrence, and 100% of the people, all of them, they were free of metastatic disease. In the United States, the standard of care remains to, after giving 2 cycles of ipi-nivo, is to do a complete lymph node dissection. And